Okay, let's continue from where we ended. We are looking at this question. How does PTH maintain calcium levels by acting on the bones? We said PTH can act on the bones, the kidneys, and the digestive system. So we are trying to ask, just to explore this mechanism of action of PTH on the bones. So PTH enhances the resorption of calcium from the bones. Resorption, we know it's dissolving, okay, dissolving the bones by acting on osteoblasts and osteoclasts of the bone. So resorption of calcium from bones occur in two phases. The resorption of calcium from the bones occurs in two phases. There is the rapid phase and the slow phase. Let me just say something about, just from the name rapid, it occurs fast. It occurs within minutes after the release of PTH from the chief cells. So immediately after reaching the bone, the PTH gets attached with the receptors on the cell membranes of the osteocytes. So they form what we call the hormone receptor complex, which increases the permeability of the membranes of these cells for calcium ions. Therefore, it accelerates the calcium pump mechanism so that calcium ions move out of these bone cells and enter into the blood at a faster rate. That's why it's called the rapid phase. So PTH will bind to the receptor, and these receptors are on the osteocytes. Okay, and there will be transduction mechanisms inside the cell. At the end of the day, we have the expression of the calcium pumps, so that the calcium from the bone matrix is pumped out it enters into plasma, therefore increasing the levels of calcium. And then we have the slow phase. Okay, just from the name, it's slow. Okay, so the slow phase of calcium reabsorption is due to the activation of the osteoclasts. So this one is due to the increased permeability of the osteocytes. But here it's due to the activation of the osteoclasts by PTH. So when the osteoclasts are activated, some substances such as proteolytic enzymes, citric acid, and lactic acids are released from the lysosomes of these cells. Okay? Proteolytic, meaning they can break the proteins. Citric acid, lactic acid, these are released from these osteoclasts. And all these substances will begin to digest the what? The matrix of the bone, resulting into the release of calcium. And then the calcium will enter slowly into the blood. Okay. Apart from that, the same PTH, apart from activating the osteoclasts, the same PTH will increase the proliferation of the osteoclasts. Okay. So from your histology or anatomy, you should be able to distinguish between osteoclast and osteoblast. Osteoclast, in this case, they are these cells that, they are bone cells that increases bone resorption. Okay. Now there's this diagram which is actually showing the mechanism by which PTH. Okay, let's start from here. It's a simple diagram. Okay. We have the parathyroid hormone there. Okay, so it binds to receptors on the osteoblasts. Okay. This causes them to form what we call a receptor activator for nuclear factor K B, ligand. It forms a receptor activator for nuclear factor, kappa, ligand. Okay? And also, it causes the release of this, the macrophage colony stimulating factor. Let me repeat. PTH, or vitamin D, when it binds to osteoblasts, they begin to secrete this chemical messenger. A ligand, you know, it's a chemical messenger. So now this ligand is called rank. We'll just call it rank L. And then it also stimulates the release of the macrophage stimulating colony stimulating factor. So what happens when these are released? The rank L, it binds to the rank. Okay? It binds to the rank. No, it's a pre-osteoclast. Now it has receptors. We call them the rank. And then the macrophage colon stimulating binds also to its receptors here. These are receptors. So the rank L ligand will bind to the rank. And we said rank is the receptor activator of nuclear factor, kappa. And then when that happens, it increases the conversion of pre-osteoclast cells to osteoclasts. Okay? So the pre-osteoclasts, they will mature to osteoclast. Now, there's this also this. This is OPG. OPG is just osteoprotegerine. When PTH binds to the osteoblast, it also decreases the production of osteoprotegerine, OPG. And we know the function of OPG is to inhibit differentiation of pre-osteoclast into mature cells. So there's a balance. Rank, it increases production of osteoclast. OPG inhibits the production of osteoclast. So there should be this balance. This is what we need. This is called homeostasis. You get the point? Yes, it's called homeostasis. When enough calcium is available in the blood, what happens? The OPG levels will increase. Okay, so you are going to see that in clinical practice, the measurements of these OPG rank levels in the blood, these are important in assessing the condition or the status of the bones. Okay, in terms the person has ricket, osteomalacia, or osteoporosis. So it's important just to know the levels of OPG and rank ligand. So the mature osteoclasts, we have now the mature osteoclasts. They develop like finger-like projections. And then they begin to release the acid, the citric acids. Okay. They begin to release the citric acids, the lactic acids, and the proteolytic lysosomes. And then they begin to digest the bone here. Okay. And then we have availability of calcium in the blood. Okay, so this is the mechanism by which PTH acts on the bone to increase bone resorption. It first of all binds to the osteoblasts. The osteoblasts, they secrete rank L and macrophage colon stimulating factors. These two chemical messengers, they'll act on the pre-osteoclasts and converts them to mature osteoclasts. And we know the function of the osteoclast is to digest or to resorb the bone so that there's available calcium in the blood. Okay. So we've seen how PTH acts on the bone. Now let's also, we also say that PTH acts on the kidneys. How does it do that? PTH acts on the kidneys. The notes are very well explained. PTH increases the reabsorption of calcium from the renal tubules along with magnesium ions and hydrogen ions. It increases calcium reabsorption mainly from the distal convoluted tubule, the proximal part of the collecting duct. Okay. PTH also increases the formation of 1,25 dihydrocholecalciferol, which is an activated form of vitamin D. So this 1,25 dihydrocholecalciferol comes from 25 hydrocholecalciferol in the kidneys. So this is straight, it's well explained. It just increases the absorption of calcium by the kidneys so that we do not lose calcium, okay, in urine. The calcium should be reclaimed. Now the other thing, how does PTH maintain calcium levels by acting on the digestive system? How does PTH maintain calcium levels by acting on the digestive system or the gastrointestinal tract? The notes are straightforward. PTH increases the absorption of calcium ions from the GIT indirectly. Okay. It increases the formation of 1,25 dihydroxycholecalciferol in the kidneys, which is an activated form of vitamin D. So this vitamin will move in circulation in blood, and then it has specific receptors on the GIT tract. So when vitamin D binds to specific receptor on the GIT tract, it will increase the absorption of calcium from the GIT, from the diet. Okay, so the calcium from the diet would not be released in fecal matter. Okay, it will be reabsorbed. So the sources of calcium, we know that calcium from our diet are things like milk, cheese, vegetables. These are rich in calcium. Okay, and PTH is also essential for the formation of activated vitamin D. So that's a mechanism of action by which PTH maintains calcium levels by acting on the digestive system. Okay. Now we know that PTH increases the formation of activated vitamin D. How? So do not confuse these concepts which I'm trying to say. You need to understand these concepts one by one. So that's why I've put them in form of questions. These are different questions. So like this question, how does PTH increase formation of activated vitamin D? How does it do that? So this diagram is very straightforward. We know that vitamin D is very essential for calcium absorption from the GIT. But vitamin D itself is not an active substance. Instead, vitamin D has to be converted into what? 1,25 dihydrocholecalciferol. Okay? In the liver and kidney, in the presence of a hormone called PTH. So 1,25 dihydrocholecalciferol is the one which is an active product. So we'll start here. It's important to know that there are various forms of vitamin D. Let's start from here. It's important to know that there are various forms of vitamin D, but the most important form is the D3, which is also known as the cholecalciferol. Okay. Now this cholecalciferol is synthesized in the skin. That's why it's important to expose our bodies to the sunlight, because sunlight activates the synthesis of vitamin D3. So we are saying it's synthesized in the skin from where? From 7-dehydrocholecalciferol. I haven't shown it here, but there is 7-dehydrocholecalciferol somewhere there. Okay. By the action of UV light. So UV light converts 7-dehydrocholesterol to cholecalciferol in the skin. Okay. It is also obtained from dietary sources. This vitamin D3. Okay. So once we have, follow me clearly. Once we have cholecalciferol, it has to be activated to 25 hydroxycholecalciferol. Okay. The first step is that it is converted to 25 hydrocholecalciferol in the liver. This process is limited and is inhibited by 25 hydrocholecalciferol itself. This is normal. These are called negative feedback mechanism. This inhibition is important so that we regulate the amount of active vitamin D. Also, the storage of vitamin D for months together, it's also essential. Okay. Let me repeat. The importance of this inhibition is important for two reasons. One, regulation of the amount of active vitamin D. Also, storage of vitamin D for months. Okay. So if vitamin D3 is converted to 25 dihydrocholecalciferol, it remains in the body only for 2 to 5 days. But vitamin D3 is stored in the liver for several months. Okay. Now the second step here. What happens? The 25 dihydrocholecalciferol is converted now to 125 dihydrocholecalciferol, the activated form of vitamin D, which is also called decalcitriol. So this conversion needs the parathyroid hormone. Okay. And then we know that the 125 dihydrocholecalciferol will act on the intestine, increasing the absorption of absorption of calcium. Okay. So in the intestinal epithelium, it will have effects called calcium-stimulated ATPase. There will be alkaline phosphatase. There will be calcium-binding protein. What we have is intestinal absorption of calcium. Okay. So alkaline phosphatase is an enzyme. It's an enzyme. Okay. So let me just repeat this step. Conversion of 25 hydrocholecalciferol to 125 requires the presence of parathyroid hormone. It requires the presence of parathyroid hormone. Okay. This is very straightforward explanation. Now, what is the effect of calcium ion in regulating 125 dihydrocholecalciferol? Okay, increase in calcium concentration directly suppress the conversion of 25 hydrocholecalciferol into 125 dihydrocholecalciferol. This effect is very mild. Increase in calcium ions concentration decreases PTH secretion, which in turn suppresses the conversion of 25 hydrocholecalciferol into 125 dihydrocholecalciferol. which is not mild. This is the most significant effect of calcium on regulating the production of vitamin D, or activating the activated form of vitamin D. Okay, so there's this diagram which I've shown you here just to appreciate what really happens when this 125 dihydrocholecalciferol acts on the intestine. Okay, when it acts on the intestine, it increases the calcium channels on the lumen side. It also increases the production of calbindin D28K. This calbindin, it binds calcium so that more calcium can easily be absorbed. At least it has somewhere to go. Unlike if there was no calbindin, though it will reach a concentration, it will reach equilibrium, so there will be no movement of calcium. But as long as the calcium is bound to the calbindin, more calcium will keep on moving in. And also it increases the activity of the calcium ATPase. Okay, it increases the activity of the calcium ATPase. Okay, I've talked too much, but it's just important to know that this is how PTH is able to activate the cholecalciferol, which is in the skin, and then it is converted by the liver to 25 dihydrocholecalciferol, and then this 25 dihydrocholecalciferol is converted to the activated form of vitamin E.